Mrs. President, committee members of AIUM, members of AIUM, I'm very honored, I'm very pleased to be here and to be invited to speak to you and certainly to receive this very prestigious prize. Because AIUM is the greatest society of ultrasound in medicine. I think we can rightfully say this. And this is also illustrated by a paper in the Lancet which shows the impact of AIUM and the impact of Professor Benasseraf as a person, because it's quite rare to have a full page dedicated to one person in the Lancet. But this talk is, reading the title, it says tips and tricks. Well, there's some tips and tricks, not so many tricks, many tips. And the first tip I would like to give is to start reading books of the luminaries. And there's two real luminaries sitting in the room. It's Professor Stephen Goldstein and Professor Ilan Timur. Steve Goldstein is past president of AIUM, and he was really one of the first people who encouraged me to continue back in 1996, I think, in Chicago. He came after the lecture and he encouraged us and he showed real interest. He was there at my PhD defense in 1997, and throughout the years we've been in touch on many occasions. Steve, it's impossible to list all your achievements and your presidency of ACOG and other societies, but you're very well known as being a superb teacher and really one who encouraged young people to start doing their career, to do research with enthusiasm. So thank you for this. Another person I would like to mention, and I adored reading the books of Art Fleischer. And Professor Fleischer is also in the room here, and he was recipient of the William J. Frye Lecture Award in 1999. And he was really a pioneer in combining beautiful drawings with histology slides and with ultrasound images. Thank you, Art. And here comes the first tip: select an interesting and important research topic. And so I did. I chose how to classify and manage ovarian tumors, because as a gynecologist we struggle daily in our practice to classify benign tumors from normal ovaries, from functional cysts, from borderline tumors, invasive tumors, and metastatic tumors. And to do this, to solve this problem, you need an international multi-center collaboration, and not only with peers, but also with statisticians, with engineers. So it's very important to work together. And in this way, there's one word: reciprocity. And I learned that it's try to do the good, or to do as good as you can, but don't expect anything in return. And the second thing comes later: you will continue to be pleasantly surprised. And in order to speak together and to work together, you have to speak the same language. And you may hear that English is not my native language, so I'm not a native speaker, but I learned a few things from my friends, and we sat together on many occasions, and so we tried to come to a consensus, because what you call population is not what I call population. So you have to discuss what is really a population, you have to set definitions, and I know it's arbitrary, but if you don't do this, you can never do any proper research, and your research will not be reproducible. So this is how we started, by defining terms, definitions, and measurements to describe sonographic features of ovarian tumors. And for example, you can look at the amount of color, the amount of vascularity at Doppler, but you can also look at the morphology, and you see that the color score is 1 if there's really no flow. Color score 2 is given when there's only minimal flow. You have to look very hard to detect some flow inside the tumor or inside the wall. Color score 3 means that there's rather strong flow. And color score 4 is given when the adnexal mass appears highly vascular and with marked flow. But immediately you see there's overlap between benign corpus luteum, a functional cyst, and the one you want to detect, cancer. So not any ultrasound feature or Doppler feature is able to give you the right answer. So you have to combine different features, and only then you get the best results. And then you need a plan. And a plan is a logical flow of studies in order to achieve your goals. And we started back in 1999 with the first model development. First we collected over 1,000 patients, and then we tried to make models together with the engineers. We looked at the value of the serum tumor marker C125, and then you have to validate it, because it's all fine to make something that works in your center, in your hands, but is it generalizable? Is it valuable also in another country, in another situation? And therefore, we had IOTA 2, external validation, IOTA 3, new second stage test, IOTA 4, performance in the hands of less experienced examiners. And this is very important as well, because if only the luminaries can use it, it's of no use. You really want to raise the level of quality overall. And so every sonographer, every colleague should be able to use it. And then finally, it's a long-term behavior of non-operated adnexal masses. Another tip, find good statisticians. And I struggled with this in the beginning of my career, and now I know how important this is. If you have to do it yourself, you fail. If you have a very expensive statistician, it's not going to work. But if you have good statisticians, you can discuss study setup, you can discuss the primary aims, the secondary aims, sample size, statistical analysis, when writing the protocol. So you have to do it at the start of the study, not as many people do at the end of the study, because then it's a mess and you cannot correct for the errors that have been made over the study. But there's one trick. You have to feed them with coffee and chocolates. Preferably Belgian chocolates. Simple ultrasound rules are appealing for people who have a busy clinical practice, who have no computer available. And this dates from ancient times, when nothing was installed in ultrasound machines, when apps did not exist. So we needed simple rules. And this is something you can cut this table and stick it onto your old-fashioned ultrasound machine. And if you then see that the patient has ascites and 4 papillations, it's called a malignancy. And IOTA simple rules are based on 5 features of malignancy. The first is irregular solid tumor, presence of ascites, at least 4 papillations, irregular multilocular solid tumor of at least 10 centimeters, and color score 4, so very strong flow. The benign features, unilocular cyst, a tumor with a larger solid component less than 7 millimeters, acoustic shadows, smooth multilocular tumor less than 10 centimeters, and color score 1. You see, color score 2 and 3, they don't exist in the simple rules because it's arbitrary and there's overlap. So only if there's no flow or very strong flow, simple rules will be based on color score. If there's color score 2 or 3, it's not applicable. You cannot use it in simple rules. But these simple rules seem to be pretty reliable, because in this external validation paper, you see that the sensitivity for cancer, the detection, is 92%, while specificity is also very high, 96%. And it gives us great pleasure to see that the Royal College in the UK took over the simple rules to classify suspected ovarian tumors in premenopausal women. But in order to facilitate their use, we also made IOTA models, and if you go to IOTA models on the Apple Store, you can have it for free, and then you can download this and have logistic regression model 1, 2, and the simple rules, and you see some explanations. So there's a help function to explain what is color score 4, what is the population, so it's all in there. So this gives an overview of all IOTA phases, and IOTA 1 to 3 were based on experienced examiners. In IOTA 4, we used non-experts, so junior doctors, sonographers with limited experience, and proved that even in their hands, the models lived up to the expectation, and it had almost the same performance as in expert hands. But then we also started in IOTA 5 with follow-up of patients, because then only you can classify all the tumors that you see in your clinical practice, because very often you see a benign tumor that doesn't need to be operated upon. Also, small cysts in postmenopausal women, they do no harm. Simply leave them. But in order for this, to prove this, you need a very large study, and this is IOTA 5. And IOTA 5, and Wouter Voigtman is here in the room, and so if people would be interested, you can go to him and ask whether you can take part, because some more participation from the United States and Canada would be highly appreciated. But here we assess the real risk of complications, torsion and rupture, and I already can disclose to you that this risk is very low. It's between 1 to 3 per 1,000 so far. So it's not a reason to remove all these benign simple cysts. We also want to investigate whether there's a malignant transformation, and also the need for surgery during the next years, because if you have to operate all of them 3 or 4 years later, then there's no use of waiting and have the extra ultrasound scans. But if it's only 10% that needs an operation, then you saved 90% of necessary surgeries. So we also finally study the longitudinal changes. So if it's a dermoid-like tumor, what happens, what's the normal growth rate? So then you have some normative curves of natural evolution of non-operated benign tumors. And you see that evolution in recruitment is going very well. With an interim analysis that we did in October 2015, there were over 10,000 patients included in IOTA 5 and 5,750 for conservative management. So now the question is, we need careful follow-up of these patients to see what's happening. And maybe in 5 years' time or in 10 years' time, you may invite me again, and then I will hopefully be able to present these results. We also try to have a good geographical spread, because if you include global inputs, then it's much more likely to be picked up, and it's much more likely to be generalizable. You see, there's a very strong Italian contribution, but pickup in the United States and Canada is really increasing these days, and we are very happy for this as well. Then you need systematic reviews and meta-analysis to prove that a test is valuable, because we can publish something, but you have to prove this. And for this, there's a meta-analysis which was recently published based on 19 models, 96 studies, and in total 26,000 patients were included in this systematic review, 7,000 malignancies. And here's the results. We will not go into the details, but you can see that subjective assessment by experts is the best test together with IOTA models. So they're at the same level, and they're clearly better than the other models, which were usually made in single-center studies only. So these were very good, but if you do multi-center study, have bigger numbers, you can reach better models. And then finally, if you have a lot of data, your statisticians and engineers will be happy, because then they can do more refined modeling. And refined is not simply saying this is benign or malignant. No, you can also say this is probably benign, or it's probably borderline, or early stage invasive cancer, or late stage invasive cancer, or it might be a metastatic tumor. So a breast cancer or colon cancer that has metastasized to the ovary, and this might be the first lesion that you see. If you know that it's likely to be a metastatic tumor, then you can do additional testing, mammography, coloscopy, and try to find the primary tumor before doing a simple surgery or a complete resection of the tumor. And this is illustrated by this case. It's a 59-year-old woman, loss of appetite, no family history of ovarian cancer, and you can see a solid tumor, there's ascites, C1 to 5 is elevated, it's 154. And if you then apply the app, or you can go to the IOTA website, and then you can calculate the risk. And on the left side, you see all the IOTA patients, and on the right side, you see the personal risk of this patient. And simply looking at the color, you see this is not good. It's advanced stage or it's a metastatic cancer. So the prior risk of metastatic cancer was 4%, and the posterior risk is 21%. And it was a metastatic stomach cancer, so a Kuchenberg tumor. So then debulking surgery is not the best treatment, so you need to treat this patient in a different way. And then finally, as already mentioned in IOTA, the simple rules had serious drawbacks, not because they're simple, but because they could only classify 70% of tumors as benign or malignant. And they did not assign a risk score. So in this study, we overcome this problem by assigning a risk score. The study was based on 4,848 patients. AUC in oncology centers and in regional centers was similar, and the risk estimates were very well calibrated. And the study can be summarized in here. If there's no malignant features in the simple rules, and there's more than 2 benign features, then there's a very, very low risk of malignancy. And probably it's very safe to leave these tumors if the patients are asymptomatic, because you will do much more harm than good by operating all of them. If there's no M features and 2 B features, or no M features and only 1 B feature, but that's unilocal assist, then the risk is low. If there's no M features and 1 B feature present, except for B1, it's intermediate risk. And then you can see if there's more M than B features, there's a very high risk of malignancy. So we hope that this will be included in the excellent initiative taken by Professor Phyllis Glantz, by Professor Goldstein and Professor Benasseraf, by trying to come to a consensus. And now this has moved forward by the American College of Radiology, and so we hope that there will be a very good agreement in the future and come to better use of ultrasound in classifying ovarian tumors. We also organize some conferences, and the 3rd edition will be in February 2017 in Leuven, Belgium. So if you like chocolate and beer, you can come to Leuven. Or you can maybe join the Hall of Fame, like Misty Blanchette Porter. She's in the Hall of Fame, and you see these were the best achievers in the IOTA multiple choice question test. So this is a very tough test, and some people manage to get 20 out of 20, and so here are the best achievers. So in all, 2,500, because this is outdated now, but 2,500 people have set the test, and even Professor Goldstein is among them, and he's very brave. And so in total, 16,000 patients have been included in different IOTA studies, participants from 28 countries, more than 7,500 downloads of the free apps, IOTA models. And then just a few words about other projects, because IOTA is the start, but 10 years later we started with AITA. And AITA is really endometrial tumor analysis. And again, it was terms, definitions paper that was followed by protocols. This paper was downloaded quite a lot because people like standardized papers and like to see what's the nomenclature. And for example, you can look again at the vascularity, the amount of vascularity, but also at the pattern. So a single dominant vessel without branching, with branching, multiple vessels with focal origin or multifocal origin, and then scattered vessels and circular flow like you see in fibroids. And in different phases of IOTA, phase 1 is looking at patients with abnormal bleeding. 2 is incidental findings, no abnormal bleeding, but you see something wrong in the endometrium. And 4 is patients with endometrial cancer, so proven cancer, and you want to do preoperative staging with ultrasound. And also here, there's 1,700 patients with cancer included already. So over 6,000 patients in total. And then finally, early pregnancy, and of course, I'm so happy that Aris Papageorgiou is here and that he will be honorary fellow of the AIUM as well, because early pregnancy was sidelined for many years, and I think it's really the group of London with Aris Papageorgiou, George Condes, who vitalized this area of research. And reliable dating of pregnancy, pregnancy of unknown location, and a reliable diagnosis of pregnancy is among them. But there's many more faces that you can recognize here, and all of them started as young fellows, exceptional young fellows, I must say, and they were nurtured, and they're still very close in collaborating in different studies. So I think if you want to make a project sustainable, you need to include young talents and young colleagues and encourage them. And also here we had to harmonize the nomenclature, because pregnancy of unknown location in the United States was completely different from what we called pregnancy of unknown location in Europe and in England. It's one, I know, but Europe and England may be separated in the future, so we hope not, but it's your choice. But we have to speak the same language, otherwise, again, we cannot compare our studies and our results. And we hope with this that this problem is solved as well. There's also apps for early pregnancy where you can use models to predict in cases of pregnancy of unknown location, whether it's highly likely to be an ectopic pregnancy or failed pregnancy or an intrauterine normal pregnancy. But the most difficult diagnosis in early pregnancy is not what a junior has to make, it's really what the highest person in rank has to make. That's a diagnosis of miscarriage. Because you should get it right. You should not treat a pregnancy that is maybe still evolving or maybe ectopic and treat it as a miscarriage. And if you look, for example, in the study that was published by Tom Bourne and colleagues, if you use mean sac diameter of 16 millimeters, then your false positive rate of miscarriage is 4.4%. So this means that thousands of patients will be labeled with possible miscarriage and have actually a normal pregnancy. And if you use 20 millimeters, it's 0.5%. The Royal College again was quickly to take this into their recommendations, and they said you can only make a diagnosis of miscarriage if the mean gestation sac diameter is at least 25 millimeters, or if the crown rump length is at least 7 millimeters. And some of us will disagree and say, well, I've never seen a case of 6 millimeters where the crown rump length, no heartbeat and normal pregnancy. Well, if you use it in the wider community, things happen. And that's why you need to be careful with guidelines. And therefore, I think it makes sense. And I would recommend you all to read this beautiful paper in the New England Journal of Medicine, published by Peter Dubele, Carol Benson, and then again Professor Benasser, Goldstein, Misty Blanchette-Porter, and Ilan Timurtic. And that really sets the scene, gives clear guidance when to make a diagnosis of ectopic pregnancy. And then expect the unexpected, be invited with a queen, go to the Royal College, and there, much to my surprise, it was Steve Goldstein who got the fellowship at AIUM at the same session. So this was really a wonderful setting, and to me the circle was round. So this is all thanks to 20 years of collaboration in gynecological ultrasound, and I think the tips are here. It's really nurture the culture of trust, respect, friendship, start with a consensus, terms and definitions, good study protocols, good statisticians and prospective studies, integrate young, excellent, complementary persons in the team, be extremely critical in rereading your manuscripts and a little Professor Lil Valentin is wonderful to do this. So every paper we have at least 20 revisions, final, up to 20 before it's being submitted. Follow the technical evolutions, Facebook, apps, translational research, and make sure that your research has impact on clinical practice and above all on patient care. Thank you.